Hello, this is Dr. Bhaumik, and again, welcome to my lecture series, The Keeping Up with the Tempo of Neonatal Endocrine Emergency. The last lecture was on neonatal and children's hypoglycemia, and today I'm going to discuss about hypocalcemia. Again, this lecture has been developed keeping in mind that this will be most helpful for pediatrician, pediatric house staff, pediatric nurse practitioner, and pediatric and neonatology fellow. And I have made the highlight of the hypocalcemic discussion, realizing fully well that hypocalcemia, like hypoglycemia, is a very big lecture series, but I will only highlight which is most important to the pediatrician and house staff, and to make sure that this covers for those who will be taking USMLE and pediatric board examination as well. With that background, let's divide the hypocalcemia in two parts. First, let's discuss about the early onset hypocalcemia in neonate, and it's rather common. Any neonatologist or pediatrician knows that early hypoglycemia occurs usually 1 to 2 days of the age, and most of the time without any interference, is stabilized between in 2 to 3 days. We also know about 30% of preemies and the neonate with birth asphyxia may have serum calcium less than 7 milligram per dl. And also, half of the infant of diabetic mother may also exhibit a serum calcium level 7 or less than 7. Now let's discuss in nutshell the pathogenesis. I am going to discuss the high point. So why preemie develop hypocalcemia? Well, we know the calcium deposit occurs in the last trimester of the pregnancy. Maximum calcium deposit occurs in last trimester of pregnancy. And that is lacking in preemie. There is a decreased parathyroid hormone response to hypocalcemia, and obviously preemie is not taking that much calcium by mouth, and so there is deficiency of calorie as well as calcium in the beginning. And then if the baby born with neonatal hypoxia or asphyxia will be probably better term, then they do develop hypocalcemia, which is mostly secondary to endogenous phosphate release. As we know that if the patient is asphyxiated, the cell release a lot of phosphate, which actually bind with the calcium and therefore decrease the level of the calcium. And the other thing also happened, the calcitonin level goes up, and which interfere with the withdrawal of calcium from the bone. Infant of diabetic mother may have hypomagnesemia and decreased PTH response, and therefore might develop mild hypocalcemia. And that's kind of described as functional hypoparathyroidism. One of the reasons that the baby might develop hypomagnesemia, because we know the mother with diabetes uh, during the pregnancy or the later part of the pregnancy usually uh, usually lose lot of magnesium through the urine. What about the late onset hypocalcemia? Late onset hypocalcemia occurs between 3 to 7 days of age, and most of the time it is because of the phosphate in the cow's milk, too much phosphate in cow's milk, and everybody is actually aware of that. And if the baby has neonatal hypomagnesemia, as seen in infant of the diabetic mother in some many cases, and they might develop a low PTH release and therefore mild hypocalcemia. And idiopathic hypoparathyroidism, we do not know why, but this is transient and they exhibit the sign symptoms as well as the laboratory finding of low calcium and suppressed PTH response, and over the period of time everything stabilizes. That is a transient hypoparathyroidism. But there is another condition which is rare but can be present if the mother has hyperparathyroidism during pregnancy. Hyperparathyroidism. This is where the mother's calcium level is high, parathyroid hormone level is also high. So calcium is transferred to the baby at higher rate than it would have been, and that has also suppressed the baby's PTH secretion from parathyroid. So that has interfered with the maturity of parathyroid in babies, and therefore when the baby is born, when the calcium is gone, then the PTH response has been lagging. And indeed there was a study which showed about 5% of the mother with hyperparathyroid adenoma or hyperparathyroidism was diagnosed because by detecting the low calcium in the babies. And so hyperparathyroidism in mother has to be kept in mind. So treatment of hypocalcemia, actually I have put this slide here for the completion of discussion. And I would recommend that although the dose and everything is written here, but make sure you double check before you give any calcium IV infusion. Calcium gluconate is used because it is less toxic to the extra when there is extravasation of calcium. Calcium chloride is about 3 times more stronger in terms of elemental calcium. So it's about 10 versus 30. So calcium gluconate is preferred. Then while you are giving calcium, IV especially, one need to monitor the heart rate, as well as have to be extremely careful that the calcium is not leaking and vein is not injured and calcium is not leaking, and then there could be a problem. And next I'm going to talk about another important area which get much less respect, but they ought to think always about magnesium. And study shows as many as 80% of the infant with hypocalcemic seizure may have low magnesium as well. So always check magnesium, and we also know that hypocalcemia will be difficult to correct. Hypocalcemia will be difficult to correct if the magnesium level has not been corrected or stabilized to a normal range. Now, we also know that the magnesium probably does not interfere with the synthesis of parathyroid hormone, but it certainly does interfere with the release of parathyroid hormone. And as I said, that magnesium also should get equal respect, and magnesium should be supplemented if the hypomagnesemia and hypocalcemia both detected, and the dose has been here on the slide, but as I said, it has to be checked before you give. It can be given IV drip, it can be given IV, or it can be even given intramuscularly. And oral dose also, I put it there, but again, double check. When it comes to the medicine dose, medicine always double check. Now that we talk about the calcium problem in the neonate and infant, now let's talk some of the important calcium issue. As I said, some of the important calcium, which is certainly not a complete list and which is not possible to do in this lecture. But the one that comes in your examination and what will be more important for you to know is that childhood and adolescent hypocalcemia, one of the common clinical entities, but it is still very rare, called pseudo hypoparathyroidism, and also PHP, most commonly known as PHP type 1A. There is a type 1B, and you know how many type they have. Every time I open the literature and see that there is always another type has been described. So in order to make you less confused, I'm going to talk to you about few of them that you need to know. So in pseudo hypoparathyroidism type 1A, the total bone, all bone in the body, kidney is unresponsive to PTH hormone. So this is resistant to this area, the peripheral organ, total bone, and renal unresponsiveness. And the classical finding that you have read in the book, which also old time discussed as Albright hereditary osteodystrophy. And they are like a round face, they are short stature, obesity, and for your board examination, the short fourth metacarpal bone, the mental retardation, calcification of basal ganglia. Actually, there could be calcification, intracerebral calcification, does not have to be always in the basal ganglia. And as I said, Albright hereditary dystrophy, osteodystrophy. So what is the cause? Etiology is the mutation of guanine in AS1, and the location of this chromosome, it is on the chromosome 21. And this is the mutation of the gene that encodes the stimulatory component of G protein complex. It's actually the alpha subunit is involved, which is required to activate the cyclical AMP. So guanine nucleotide AS1 on chromosome 20. Now this is the best example of short fourth metacarpal bone. This is short fourth metacarpal bone. This is a very nice picture. Look at that, and it can be in your exam. And remember, there is another condition where you can have short fourth metacarpal bone which people tend to forget, is the Turner syndrome. Rare, but it has been reported. And there is this X-ray comparison. Here is the short fourth metacarpal bone, and this is the normal hand X-ray. As I said, the calcification does not have to be in basal ganglia, but that's the typical for your board examination. But it could be intracerebral anywhere, a beautiful outline calcification. Now let's talk a little bit about pseudohypoparathyroidism type 1b. Well, these biochemical features, the blood picture is the hypocalcemia, elevated PTH is exactly same as type 1, but there is no phenotype typical features of type 1a. So they look completely normal, no phenotypical features. And if you look at the normal G activity, they have a normal G activity in the genetic system, and it is believed it most likely a PTH receptor defect. Again, there are lots of supposition and disagreement, but possibly PTH receptor defect, and this is the one may manifest later childhood or at puberty. I have two patients in my clinic, in my endocrine clinic, who presented, one at the age of 9 and another at the age of 12, and had a seizure in the school, and they have no clinical stigma or finding that will tell you they are pseudohypoparathyroidism, and both of this child was African American. I don't know whether that has anything to do, but I just want to mention, and both of them are male. So anyway, so this is another thing that happened later on childhood. The another one that is really very interesting board question, and that is 22q11.2 deletion syndrome. That's what they call, but for me, I still remember and like to call that one is Dizor syndrome, Angelo-Dizor syndrome, and many people know them probably better in that way. So the chromosome deletion is, as I said, 20q11.2 deletion syndrome, and also known as catch-22 syndrome. Why it is catch-22? I'm going to go that with you, and which is a very nice way that you can remember. C stands for cardiac defect. Then most common cardiac defect is tetralogy of Fallot and aortic arch anomalies, interrupted aortic arch, right-sided aortic arch, and so forth. And they have A's for abnormal faces that typically they call fish mouth deformity, and a narrow face, and they have thymic aplasia, cleft palate, narrow long face, low calcium and depressed immune system. So most commonly in Dizor syndrome, they would like to know that they have what kind of cardiac defect, and they have aplasia of hypoplasia or aplasia of thymus, therefore hypocalcemia. And since there is a problem with thymus, they are also has depressed immune system. So remember the Dizor syndrome, a very favorite board question. Then hypocalcemia can result from hypoparathyroidism in children or adolescent. This entity is rather uncommon. And there is only thing that I'm going to tell you, that when you evaluate this patient, if you have a low calcium, high phosphate, and low PTAs, low parathyroid hormone, this triad is the diagnostic of hypoparathyroidism. So if you remember that, that would serve you very well in your exam, and as well as for knowing this triad: low calcium, high phosphate, and low PTAs. Actually, hyperparathyroidism is also less common, but it is a little bit more than hypoparathyroidism in children and adolescents, and most of the hypoparathyroidism is associated with the syndrome like a DJORS and the one that I have discussed in my lecture. Thank you very much. My next talk will be pediatric hypercalcemia. Again, neonatal children and adolescent hypercalcemia. Thank you very much.